All right. Any questions from the first or from last time? No, we got through our pain management stuff into talking about RA and all of that. So to kind of talk more about, we talked about our non-biologic DMARDs. We talked about the traditional ones like methotrexate and whatnot. Moving into the biologicals, these are going to be more protein-based. In a lot of cases here, which route do you think these have to be given by for biologics? Yeah, usually injection, right? So most often either sub-Q or IV in a lot of cases. They tend to be pretty effective at what they do, but they're also quite expensive. I mean, these are going to be thousands and thousands of dollars a year to take these, but they can be, pretty effective. The other benefit is very little monitoring, so you don't have to worry about things like hepatic function and renal function while taking these drugs here. But do know that because they are very efficient at suppressing the immune system, that you do have to monitor for infection, right? So immunosuppression is going to be a big risk with these ones here. And for the majority of them, you want to test for TB beforehand. Why is that? Right, and so. Right, so if they have a latent TB infection, I don't want to activate that by suppressing their immune system. So that's why we're going to be testing beforehand. Most of them have like a black box warning on that. They have to check for it. And typically we would say, like, if they have an infection, discontinue use during that time. So that way it kind of gives the body a chance to kind of recover itself before you go back on it. And typically we don't give live vaccines. What do you think that is? Yeah, they can actually get the disease itself, right? So you can give them, say for instance, like a inactivated form of the vaccine, but it may not be as effective while they're on this immunosuppressive therapy. But for instance, if it's the flu season coming up, these patients, we know they're at risk for flu anyway. Even if they get a bit of a diminished response, it's probably still reasonable for them to get the inactivated form. I would not give them the live attenuated form, right? Because then they could get the disease itself, as we mentioned. A couple different targets we can shoot for with these medications here. So for instance, we have tumor necrosis factor alpha. We know it's an important inflammatory mediator here for activating a lot of these inflammatory cells. We will have several that work on this, and interestingly enough, some of the side effects you can see with this, kind of a rare one, would be exacerbation of CHF in patients that have that. So you would want to be cautious with these patients, make sure you're monitoring their weight, and make sure they're not developing a lot of edema and fluid accumulation and whatnot. And then in patients with multiple sclerosis, you can actually induce or exacerbate their symptoms, which is kind of a unique sort of thing there. And there is a black box warning for some slight increase in cancer risk, but again, you have to weigh the risk versus benefits in those patients there. We have a couple in this category. So we have Etanercept or Enbrel. This one is actually, if you look at it, actually looks like tumor necrosis factor receptors, and it's kind of bound to the Fc portion of a antibody. So it's kind of a unique sort of structure there. It's not just a pure antibody like some of the other ones we'll look at. But the goal here is it will bind to that TNF, and then the immune system will take care of the rest of it since it's being bound up, right? So basically taking it out of the equation in terms of activating the inflammatory cascade. Generally, you're going to see that these can either be used by themselves or in conjunction with the traditional DMARDs. Oftentimes, we'll see methotrexate plus used to something like Etanercept, right? And again, these are going to be protein-based. You have to give them via injection. Some we'll see are going to be more likely to be used IV. Some of them are going to be more likely to be used subcutaneously. This is one they could potentially use at home as a sub-Q drug there. Biggest risk typically are going to be injection site reactions, and so do want to at least warn them about that. Make sure they're cleaning the site wherever they're injecting with like an alcohol pad or something like that. That being why? Because we don't want to introduce any bacteria on the skin there and cause infection. We know they're a big risk for that anyway. And make sure that you rotate sites around. You want to have any of that fibrosis that can develop. That tissue there can become more painful. And again, quite expensive. About $15,000 a year by my last checking on that. Infliximab is going to be a very common one. I see this a lot for kids with juvenile idiopathic rheumatoid arthritis. Here, this one's going to be a little bit bigger risk for things like anaphylaxis, and that's because it's a chimeric protein, which means it has not only human protein to it, but also has some mouse protein as well. So your patients may have a cross-reactivity with that because it is a foreign protein, right? This one you're going to find is given via IV infusion. So you actually have to have patients come back into the IV, the infusion center, and they'll have this, say, run over the course of like 2 hours or something like that, because we can monitor for any kind of infusion reactions, make sure we can treat through that if we need to, because that risk for anaphylaxis is there. Again, this one is something you'll see used in combination with the more traditional DMARDs. You may see this as an add-on, or you may see it as monotherapy for these patients potentially. Just really depends there. And another thing you have to consider with these proteins as well is that not only is anaphylaxis a risk, because your body can have a reaction to it that's that strong, but also may have a more mild reaction where your own antibodies are basically just kind of inactivating the drug, right? Basically neutralizing it to where you lose the efficacy of these drugs over time. By giving this with methotrexate, you kind of help to prevent that from occurring. So we actually find that these drugs will work better for longer if you use it in combination with something like methotrexate. Again, just to give an example of how the dosing will go, these typically have a pretty long half-life. So instead of taking, say, something like leflunomide every single day, these can be given typically at longer intervals. So for instance, this one, when they're on maintenance therapy, they can come in like every 8 weeks. So they just come in every 2 months or so to the infusion center, have that administered, and then they're good, right? So that's kind of the nice thing from a compliance standpoint. If they did have a reaction to it, say they started to develop fever associated with this, what would you give them? So you stop the infusion, but what would you administer to them? If they had a fever as relating to the infusion reaction, give them Tylenol, right? So that makes good sense. If they start to get itchy from it, you give them Benadryl, right? So a lot of times we'll actually, if we know patients will have infusion reactions, we actually give them pre-treatment. So we can actually give them Tylenol and Benadryl beforehand to make sure that does not happen. So not everyone has to get it, but if we know they're going to have a reaction, you can go and do that. If they do have full-on anaphylaxis, what would I give them at that point? Epinephrine. What else? We covered this last semester. Once the drug's there, they're having anaphylaxis. What else are you going to give them? You got the life-saving one down, but what else are you giving them? You give them oxygen, sure, but what else are you what's going to help to treat the manifestation of the anaphylaxis? Prednisone, like steroids, right? Corticosteroids, you can administer them, right? What else are you going to give them? Antihistamines, right? This is like the cornerstone of anaphylaxis, right? You got to know that kind of stuff. Epinephrine is going to be able to help with the hypotension. It's going to help with a lot of the inflammatory reaction. That's the first thing you want to have on board. And then, Benadryl or something like that, IV typically, corticosteroids, right? And so, again, you have to have like as needed orders for those available too, because again, you don't want the patient to have a reaction, the nurse sees it, and they have to call you for something. So it's important to make sure that when you're looking at things like order sets and things like that, they have these sort of as needed rescue medications there and ordered, so that way, sure they'll still call you when they have a reaction, but you don't want to make sure that you're delaying patient care because you didn't write the orders for it. So little things like that to think about. Humira, or adalimumab, is going to be another one. This one has much less risk of anaphylaxis because it's all human protein in terms of how the body's going to react to it. So this one can be given at home. It's via sub-Q injection. It comes like as a pen. Patients can administer to themselves, but think about things like, can they even give it to themselves, right? Do they have the dexterity and the wherewithal to do so? If not, then this may not be a good drug for them, right? And again, similar adverse reactions, similar risk as you would see with something like Infliximab. That's all going to be pretty similar across this group of drugs here. Etanercept is a different mechanism here, or Orencia. This is going to be for patients, typically if they're going to go on a biologic, they'll probably start off with a TNF-alpha inhibitor first. Here's some other ones we can use if maybe they fail therapy or that's not going to be a good drug for them. So here's one, it's called a co-stimulation modulator. Basically what that means is it's going to inactivate these CD receptors that are responsible for helping to activate a lot of these T cells. So by preventing that linking up from happening, they can't cause the activation of those T cells to actually occur there. So that's one way we can decrease that inflammation. Typically, again, you'll either use this by itself or you can use it in combination therapy with something like a traditional DMARD in those cases there. And again, most often this is for patients that have failed TNF blocker therapy beforehand. Another way we could do this is something called rituximab or Rituxan. This one's actually going to be working against CD20, so this actually helps to deplete B lymphocytes, and we will sometimes use this for certain types of leukemias to try to get rid of those B cells, but we can use it here as well for things like rheumatoid arthritis. This one here, you're going to see that, again, usually used for backup if other therapies have failed, more conventional sort of therapies there. This one, again, because it's a chimeric protein, you can tell because it has the X in the name, just like Infliximab did, rituximab does too. You got to pre-treat with this, right? So you got to make sure you're giving them Tylenol, make sure you're giving them Benadryl beforehand, and have those anaphylaxis meds available if need be, right? This is one I'm seeing a lot more use of lately as a backup to a TNF alpha blocker. So it's called tocilizumab or Actemra, and this one's actually targeting IL-6. So instead of using tumor necrosis factor, shooting for another inflammatory mediator there. So IL-6 will be inactivated by these antibodies here. Again, no big issues here. In terms of side effects though, or drug interactions, you would want to watch out for the fact that it does induce 3A4, which is kind of a unique thing. So that could be problematic because it could do things like, say for instance, with your statins, if you had a patient who's on, say, simvastatin, what would happen as a result of this, do you think? It's going to metabolize it faster. Okay, so how would you detect that? How would you know? What's going to happen with their lipids? They're probably going to go up, right? Because again, you have less of the drug around to actually actually get rid of that LDL, right? Things like birth control can become less effective because you're metabolizing more of the estrogen, getting rid of it, right? So ovulation can occur, things like that. So, yes, sir.
So it promotes inflammation? Can you explain that?
No, IL-6 promotes inflammation, and so by giving an antibody that will bind it up, that will help to decrease overall the inflammation you see there. Yeah. So in terms of how these are going to be working, most patients do see pretty good efficacy out of this. Some patients may take a little bit longer for it to kick in. Usually these are much faster than your traditional DMARDs, but they still may take the 3 to 6 months or so before you see full effects there. If they have a secondary sort of lack of efficacy, meaning it was working at first but now it's not really, this is more likely than not due to the body generating some antibodies against it and sort of neutralizing the drug there. So that one you would want to be cautious with or be aware of. And giving things like methotrexate can help to prevent that from occurring over the long run in some cases there. Typically, if they fail one biologic DMARD, I would switch to a different mechanism. So if they maybe failed Infliximab, say it just wasn't that efficacious, I'd probably go something like an Actemra, right? If they failed Infliximab because of, say, they had a reaction to it, that doesn't mean you can't go to something like Humira. That may be safer for them because they may be less likely to have a reaction to it. So you got to consider why they stopped it in the first place, right? Typically, I would not combine 2 biologics together, so I would not use Actemra plus Remicade because the immunosuppression would be too strong. You would not want to do that to your patients. It would be a big risk for fungal infections and viral and everything else, right? Now, corticosteroids are also going to be an important role to play in rheumatoid arthritis. We know a lot about the side effects already there, but again, these may be used as either sort of, if they're having an exacerbation, you give them like really big doses to help knock down that inflammation to get their symptoms into remission. Some cases, though, you may find patients are going to be on, say, low-dose daily corticosteroids chronically, right? And of course, you have to, what kind of things would you worry about with corticosteroid use chronically? Okay, so again, it's going to be suppressing the immune system too, right? Which is what we're using it for. What? Hyperglycemia, right? Is that the diabetes? You can see that. What else? Weight gain, absolutely. What else? How about if they're postmenopausal? Estrogen levels are going down. Osteoporosis could be worsened, right? So there's a lot of things that go along with this. If they have glaucoma, that's going to be worsened. If they have, it can generate cataracts, all these things, right? So this is something, it'd be nice if we didn't have to use daily corticosteroids, but a lot of patients, they will be managed this way, so you have to be cautious with those long-term side effects as well, right? Typically, as I mentioned, you either use it for if they're having like a disease flare-up, or maybe you can start off with one of these. If you have patients you're waiting for, say, a traditional DMARD to really have efficacy, because it may take a few months, you could use this to kind of bridge them until it has full efficacy. At that point, you could DC it potentially. Most often, it's going to be oral corticosteroids. If they're having an acute exacerbation, that's where we can use things like IV therapy, because that way, better bioavailability, and it's going to be much more potent from that standpoint. Occasionally, we'll do intraarticular corticosteroids. This is something that you can either use for osteoarthritis or rheumatoid arthritis. It's good if you have like a small number of joints actually being affected. Because again, you have to do a lot of injections, and that's not great. Typically, we don't do more than 2 or 3 a year, and that's mainly because you can actually end up finding that you can worsen the joint destruction, and you can cause things like tendon atrophy, and you can cause some tears there. So it's very effective, and they get a lot of good pain relief out of this, but it's something where you want to use it pretty sparingly. Okay. So typically, lowest dose possible is going to be the most beneficial out of a side effect profile. So you definitely want to try to get that down, but again, be aware of all the side effects that can occur over the long term. There are many, so you just have to be kind of cautious with that. So we've talked about NSAIDs before too, so you know a lot about those. You know which ones are COX-2 selective. You know which ones are going to be, side effects and things like that. Keep in mind, this is going to be like daily chronic therapy for these patients. Does this do anything to slow down disease progression though, for RA? No, but they're just going to be for symptom management. So a lot of patients will be on these chronically. If they were having, say, GI issues related to their NSAID use, say they were taking indomethacin, what could I do to help them with that? So I could do something like meloxicam. What else could I switch them to? Celecoxib or Celebrex would be good. What else could I do if I wanted to keep them on the indomethacin? It's working really well. It's just these stomach issues. Give them the PPI. What else could I use? You could use an H2 blocker. It won't be as effective as a PPI, but you could. What else? What was the other agent that kind of helped replace those prostaglandins? Remember that misoprostol we talked about briefly? Right? So it's an Arthrotec you can give as a replacement for those prostaglandins to make sure that way you generate that protective barrier in the stomach, right? Okay. In general, though, you're going to find that for osteoarthritis, some patients will get some benefit out of this, but remember with osteoarthritis, it's not as nearly as inflammatory as RA is. So you will find that this will not be the first line for patients with osteoarthritis, but certainly for rheumatoid, this is going to be kind of a go-to drug to kind of help manage their symptoms there. Just be aware to do, if I said, for instance, patient develops a peptic ulcer, what could I do to help manage that? That could be, something that could be a good question to ask on a test, right? Know these kind of strategies to do, because they're going to need an NSAID, so we got to be able to treat those side effects. So one of the good strategies to do that. Remember, COX-2 inhibitors like meloxicam, a little bit, but then more often than not, Celebrex is kind of your go-to COX-2 inhibitor. Remember, that's going to be better for patients with that GI history, but whose it might be not so great for. Yeah, if they have a history of cardiac disease, that may be a theoretical risk. It is something, again, you have to weigh the risk versus benefits. You have to kind of say, okay, well, how high risk are they from a cardiovascular standpoint? Pretty high risk, I may hold off from using something like Celebrex, right? So it's something you have to kind of weigh the risk versus benefits. And so when you're looking at a kind of flow sheet on how to kind of manage these patients here, again, typically you're going to find that, you want to start a DMARD right off the bat. And again, you may start corticosteroids along with that to kind of bridge them until their drugs kind of kick in. Typically, methotrexate is going to be kind of your first line go-to as long as they have good renal function, good hepatic function, and of course you know what to monitor to go along with methotrexate, right? LFTs, CVC, BNP, all that you're going to be monitoring for, right? Depending on how severe the disease their severity is, then you can add on things like maybe a TNF-alpha blocker, right? And you can either use the combination of methotrexate plus TNF-alpha blockers. You can use them by themselves. It just depends on how they're going to be responding to that, right? Remember, tofacitinib is a newer drug that's also going to be beneficial. It's going to have similar efficacy to like a biologic agent. That can be used in addition to things like methotrexate, but you wouldn't want to use tofacitinib plus like Infliximab, right? Because again, immunosuppression would be too strong in those cases there. Depending on how they respond to it, again, if they don't do well with the TNF-alpha blocker, that's where you want to switch them over to a different mechanism. So either go to something like, an IL-6 blocker, you can go to something like a co-stimulation modulator. Any of those options are there on the table, and just see how they respond, and you kind of go from there, right? So remember that it makes sense to use two different traditional ones. So methotrexate is usually going to be the backbone to that regimen there. It makes sense to use it with something like sulfasalazine. It makes sense to use it with something like hydroxychloroquine. I probably wouldn't use methotrexate and leflunomide because the hepatic toxicity is a little bit too high of a risk there. So I would not use that combination, okay? You can definitely use methotrexate plus a biologic, but again, no two biologics. I would not put those two together. I would not put something like tofacitinib plus a biologic. Again, immunosuppression issues are going to be the big thing there, okay? Make sense? So again, if I ask you what's a reasonable combination of drugs to control patients' RA, you'd be able to kind of pick out which ones would be reasonable or not reasonable depending on the combo that I list, right? Okay, we've talked about acetaminophen in terms of its use in pain management. We've talked about, is this going to get a lot of mileage in patients with rheumatoid arthritis, you think? Why not? Yeah, good. Acetaminophen is not anti-inflammatory, so it really has no role to play in RA for the most part. However, for OA, it's probably going to be your first-line drug, right? And we know that the max amount you can get in a day is 4 grams, right? Unless they have hepatic toxicity or hepatic impairment, then you want to go ahead and drop it down, right? To what range? Usually about 3 grams or so, right? 3250, probably at a max in those cases there. But we like to start off with this in OA because it's relatively safe, right? Most patients are going to tolerate this pretty well there. Topical NSAIDs are also good for osteoarthritis. So if you think about things like Voltaren gel, or if you think about salicylate-based creams, those can also be useful as well. And these are going to be better for a few number of joints You know, you don't want to have the patient kind of slathering it all over, but if it's just a few joints, this is going to be pretty beneficial, especially in older patients, right? Because especially as they get over 75, that's where you start to worry about the renal toxicity of NSAIDs, you worry about the GI toxicity, etc. So typically these are going to be kind of a good, you know, kind of second line thing to go with after something like acetaminophen for those patients. Capsaicin can also be really effective here too, so we mentioned that in weeks previous. What's kind of the things to think about when you're educating patients on capsaicin? Wash your hands afterwards with what? You know, just use water? Why not? It's lipophilic, right? You got to use something to get rid of all that lipophilic capsaicin, right? What else would I tell them? Wear gloves would be fine. What else do I have to tell them? Actually using the drug. Yeah, it might get worse, right? Maybe kind of hot, maybe feel irritated, right? But what happens after you use it for a while? It should get better, it should go away, right? But they have to use it consistently, otherwise if they stop using it, the substance P is going to build right back up, and that's no good, right? So most patients are probably not going to stick with that, especially if they have to use it 2 to 4 times a day. If there's several joints that are involved, they may not want to stick with this, right? Other things you could use as well, there's what we call counter irritants, so things like menthol, camphor, things like that. They may be a little irritating to the skin, honestly, like these a lot of times, or they probably used it as an over-the-counter sort of variety, but minimal efficacy, but it could be useful as an add-on there. And then, as I mentioned, you can use intraarticular corticosteroids for OA as well as RA, right? And so again, only a few times a year, no more than 3 or 4 times a year, because of the issues of joint destruction, tendon atrophy, etc. But very effective for providing some nice pain relief. Some patients feel, you know, a million times better, but then eventually it's going to wear off, and then they have to wait a while before they can get it again. Opioids. The patient's osteoarthritis, should we use opioids for them often? Ideally, no, right? So ideally, but a lot of patients are going to get started on opioids, and they frequently will have a hard time coming off of them eventually. So this is something where, you know, use it for acute exacerbations. You know, chronic therapy, though, it's going to be something where we don't have as much good evidence for that, but a lot of patients, they end up on it anyway. So I would be cautious with that if you're deciding to start that up. I'm sure most of you have heard of glucosamine and chondroitin before. This is a dietary supplement that patients can take. The idea is it helps to kind of regenerate somewhat, a little bit of that synovial lining on the joint itself. I mean, is this going to keep someone from needing hip replacement? Probably not, but it's not going to hurt in a lot of cases there. So there is some efficacy seen with it. What's kind of the caveat to remember with dietary supplements? Who regulates that? Yeah, there's not a whole lot of regulation around it, right? And so because of that, unless there's like safety issues with those drugs, the FDA doesn't really do much with them, right? They more often than not, they'll get in trouble if they make like false claims on their stuff. So for instance, you know, you could never have a glucosamine and chondroitin product that said this will fix your osteoarthritis, right? It can't say that it treats anything, but it says can promote good joint health, right? They can say things like that. And so there's been a lot of like companies will get taken down for having a lot of false advertising by the FDA, but safety is the other thing they'll come in for.
Why is it controlled by FDA? I mean, everybody's using something, so why wouldn't you control?
That's just how it's always been. Yeah, this is kind of how the regulations came about. You know, because they're not really medications specifically by their definitions there, and so that's just how they get regulated, right? So it is what it is. But again, because of that, you know, if I go and get a dose of acetaminophen from, say, Walgreens, and it says 500 milligrams on there, how much would you assume is in that tablet? 500 milligrams, right? So the thing with dietary supplements, because they don't have tight regulation on that, it's important that, you know, patients understand that it may not be exactly what's on there, right? What's actually listed. And so because of that, I tell them to stick with like one brand. Stick with it consistently, because at least you're more likely to get a consistent product. And you know, sometimes you get what you pay for, so I probably wouldn't go for like the bargain basement, cheapest, you know, glucosamine chondroitin I can find. I'd probably go for something a little bit more reputable if possible, right? Relatively safe though for a lot of patients. The only thing you do have to worry about though is the shellfish allergy, because they can actually have a reaction to that, because we actually get this from shellfish. I believe the chondroitin actually comes from, I believe we get it from shark cartilage, and I think the glucosamine actually comes up from some variety of shellfish. I have to look it up again, but anyway, so that's one thing you want them to be aware of, and not to and avoid that, to have that cross sensitivity. Another thing we can use is hyaluronate injections. This is something where you can use it in conjunction with things like intraarticular corticosteroids. Helpful, especially for like knee osteoarthritis. Basically, it has some nice anti-inflammatory properties, and it's something that your joints will normally produce anyway. Helps out definitely like mobility and things like that. Typically given once every 3 to 5 weeks or so. One thing you have to be cautious with when using intraarticular injections, you want to make sure you keep it really sterile, because if you get an infection in the joint, that can be really bad. You get things like septic arthritis, and that can be really difficult to treat because the joint's kind of a protected sort of site. You don't want to introduce any bacteria in there. But relatively safe, free of side effects. It's just you have to get that shot. So how do you manage these patients here? If they have hip or knee osteoarthritis, typically, the best thing you're trying to do is try to stave off as long as you can from having to get, surgery at that point. But, acetaminophen is going to be a good first thing to start off with in most cases there, unless they're contraindicated. They could not receive it, say, due to, hepatic impairment, things like that. Topical NSAIDs would probably be the first go-to I'd want to try out first. There's other things you could do, like tramadol, which we mentioned briefly before. But again, it's kind of going down the opioid route, and if you can keep them off of that, that's going to be, a little bit more beneficial in the long run, I think. But again, if the acetaminophen's not working, the intraarticular corticosteroids are not an option. Maybe they've just had one recently, the pain's coming back. That's where you can consider things like, obviously surgery is going to be on that list there, but opioid analgesics. A lot of these patients, oftentimes, they're good candidates, or they need the surgery, but oftentimes what's kind of keeping them from getting it? So oftentimes they have other health issues to go along with this, right? Because who do you think about as having like osteoarthritis most commonly? Elderly patients, they have a lot of health problems. Who else? Overweight patients too, right? So maybe they have diabetes, maybe they have hypertension, maybe they have other issues that are going on that kind of preclude them from getting surgery in a lot of cases. So this is where, they may need the surgery, but they just are trying to get other things in order before that can actually happen. So this is where you're going to be relying on some of these other alternative therapies in the meantime, right? For hand osteoarthritis, you can't really do much from a surgical standpoint, but certainly this is where things like NSAIDs may have a little bit better efficacy here for these patients, but again, be cautious with who you're going to use them in, the risk associated with that, and things like topical capsaicin can be beneficial here, or maybe even like intraarticular corticosteroids. So a little different in terms of treatment overall, but for the most part, go the easy stuff first, start with the acetaminophen, see how that works, and then kind of step up from there, right? Any questions on that? All right, so getting into osteoporosis, osteomalacia. Why do people develop osteoporosis? They have menopause, right? They are does that mean only women get it? Only women get it? No, men can get it too, right? Like you find there's a lot of reasons we can develop this. A lot of it has to do with sort of a disbalance between how much calcium we're laying down in the bone and actually how much we're taking out. Obviously, we're going to be in this state. We're probably taking out too much, which leading to the brittle bones there. Some of it may be related to how much we're absorbing from the GI tract. So what are some important things that help out with calcium absorption from the GI tract? Vitamin D helps to regulate that. Good. Okay, then what other things, what are some stimuli to take up calcium out of the bone? Parathyroid hormone is going to be an important thing here. And then how do we regulate how much we keep in the body once it's here, once it's in the blood? So the kidneys come into play, right? Because you're going to find that we lose calcium through the kidneys, and we can regulate how that's working. So you have patients who have poor kidney function, which we'll talk about later on in this class. You see they have a lot of imbalances between calcium and phosphate, and that can lead to osteoporosis as well. Something called renal osteodystrophy as patients can develop there, right? Why do we care about osteoporosis? Fractures are a big thing, right? Elderly patient develops, say, a hip fracture. Is that a bad thing? Very bad thing, right? Debilitating in a lot of cases. That hastens your time to death in a lot of situations, right? So anyway, there's several medications that are associated with osteoporosis. I'm not going to cover every single one of these, but some of them you can kind of make some sense out of. So for instance, we'll talk about aromatase inhibitors later on in the OB-GYN section when we get to that. That's actually an enzyme. Anyone know what that enzyme does? Aromatase? Actually converts testosterone into estrogen. So imagine if I had a patient with breast cancer and I were giving them an aromatase inhibitor and preventing testosterone turning into estrogen. Estrogen normally does what to the bones? Strengthens them, right? It actually helps to stimulate osteoblast activity and decreases osteoclast activity, right? So that way you end up having more calcium being laid down in the bone. So if I have patients on an aromatase inhibitor, osteoporosis typically follows in a lot of those situations, right? How about with a proton pump inhibitor? Why would that cause osteoporosis in some cases? Malabsorption, right? Because calcium likes to be soluble in acidic solutions. So if the pH is too high from chronic use of PPIs, guess what? You don't absorb enough calcium. Now you have osteoporosis, right? So there's a lot of different things here. Glucocorticoids I've mentioned several times already can also hasten this as well, right? Because again, it's going to be putting you in a state where you're taking up too much calcium out of the bone rather than laying it down in that situation, right? Again, remember your osteoclast are what's normally responsible for taking calcium out of the bone, right? So what stimulates the osteoclast? That we mentioned earlier. Parathyroid hormone, right? So typically your parathyroid sense that there's low calcium or low vitamin D levels, it will stimulate PTH to try to take some out of the bone, right? Because it wants to make sure you're regulating that level effectively. Osteoblasts, we want to stimulate those if best we can because that's going to lay down new calcium, okay? Certainly estrogen is going to be playing a big role here, but also think about testosterone has positive effects on the bone too. So as men get older, their testosterone levels start to wane. They can also be at risk for osteoporosis as well, right? So again, looking at this homeostasis by balancing between, say, vitamin D and PTH, remember that having vitamin D is what's going to help to absorb that calcium from the GI tract. PTH is also going to help stimulate this as well. When you take, say, a daily vitamin, you get some vitamin D. What form does that normally come in? So most typically there's D2 and D3, which is going to be in your dietary supplements, right? And those are going to be ergo and cholecalciferol, okay? Those are the typical forms you're going to be intaking. Is that the active form of vitamin D? No. Negative, right? It has to undergo a two-step process. When you form vitamin D from, say, the sun in your skin, is that the activated form? And that is not either, right? So all those forms are not active. So just because you sit on that side of the room doesn't mean you're going to have better bones than if you sit on this side of the room, right? Because you have to go through the activation steps. There's two hydroxylation steps that occur. The first one's in the liver, the second one's in the kidneys. Guess what happens if you don't have good kidneys? You don't activate vitamin D, and that's where you get a lot of issues that come about from this disbalance between calcium homeostasis, right? So anyway, so they have to have the activated form. What do I do if I have a patient that has bad kidneys or a bad liver? What can I do? I give them the activated form, right? So I can actually give them something called calcitriol, which is the activated 125 dihydroxy vitamin D. That's the thing that actually is going to help. It's going to be detected by the parathyroid. So we're going to know that, okay, hey, we have enough vitamin D levels. Okay, yeah, we can go ahead and stop sending out PTH. It's also going to help absorb more calcium from the GI tract, okay? Anyway, also you're going to see the estrogen deficiency is also going to increase the osteoclast activity, which is why we think about this in those postmenopausal women so much, right? So anyway, so our goals here are to try to prevent those fractures at all costs, right? And keep in mind, you know, it's not just the fact that they have osteoporosis. What are other things that cause falls in these elderly individuals? Maybe weakness, right? What else? Dementia, but also it's the pharm class. A lot of medications are going to do this too, right? So if I put them on a diuretic and they wake up in the middle of the night and have to go pee, they trip over something. Currently, I have to be on the lookout for dinosaurs at my house because they are everywhere. I feel like I live at Jurassic Park, but point being is if I was on a diuretic, I had to go to the bathroom, and I had osteoporotic bones and I fell, you're more likely to have those fractures there. So a lot of medications can be playing a role here, right? Anyway, once they do have a fracture, though, we want to make sure we prevent recurrence, make sure we help make sure their functional capacity is going to be maintained as well, right? So what are we going to do in terms of non-pharmacologic therapy? Calcium and vitamin D are going to be the biggest things, and this should be for almost all patients. What are some problems with giving patients calcium? Constipation is a big thing, right? So you do have to monitor for that. Obviously, calcium carbonate is probably going to be the most common form patients are going to be getting here. So they're taking their Tums, you know, it's pretty reasonable, but certainly milk can be another good source there as well, obviously. Problem with calcium, though, it can bind up with other stuff as well, so you have to make sure you're separating them out. So not to give it with iron supplements and thyroid hormones and things like that, because you will find they will not be absorbed as well, okay? Vitamin D, as I mentioned, usually 800 to 1,000 units per day is typically pretty much the recommended amount there. You're going to find that most patients are going to require some sort of exogenous supplementation, right? They don't just get enough from just sunlight in a lot of cases there, or their diet. And so, as I mentioned, ergo or cholecalciferol is the typical oral form that they will take. If they have a bad liver or bad kidneys, they're not going to have the activated form available to them, so we have to go and circumvent that and actually give the activated form. That's calcitriol, okay? So, it's prescription only, it's more expensive, but it gets around that the need to have the activated form. Looking at the actual pharmacologic therapy here, we're going to find that in a lot of cases, we may not just give patients pharmacologic therapy just because they have osteoporosis right now, but oftentimes look at their risk over the long term. So we see, okay, well, where are they heading? How might this change over time? And see, okay, well, if the risk is high enough, then we're going to go ahead and treat them, right? So here's a couple of different anti-resorptive therapies we're going to have for these patients, and we'll get into them specifically as we go forward. So the first one, this is kind of the gold standard for osteoporosis. Once they have their supplementation of calcium and vitamin D covered, this is where the bisphosphonates are going to come into play. So we have things like alendronate, ibandronate. These first three are going to be oral agents the patients can take chronically. This last one here is zoledronic acid. That one's actually IV only. And anyone know how often you have to give that? Anyone ever heard of reclass before? Actually, one time a year you have to give it. So the half-life for these drugs are very good because once they get incorporated into the bone, they stick around for a really long time. Problem though is that the bioavailability is terrible for these drugs, as we're going to see. In some cases, less than 1%, unless you're taking it exactly as you're supposed to. Basically, what these drugs do is they mimic this product called pyrophosphate, which is a natural sort of resorptive or bone resorption inhibitor. And so by mimicking what that natural product does, it's able to help decrease osteoclast activity. You're taking up less calcium out of the bone, right? So as I mentioned, less than 1% bioavailability, especially if you're taking it with any other foods or any other drinks, right? So you don't want to get up in the morning, take it with your orange juice or your coffee. It has to be just a glass of water in and of itself. That's it, right? No food to go along with this either. So typically this should be like the first thing that patients will take upon rising, depending on how often they're taking it. Sometimes it can be like every week, sometimes it's every day, depends on the situation there. But the other big thing you have to worry about with these drugs too is they have a tendency to get stuck in the esophagus, and they can actually cause erosions, ulcerations, perforations in some rare cases there. So you do want to be cautious with that. So that's another really good counseling point is once patients take this with a glass of water, they have to stay upright for at least 30 minutes. Okay, you can't just like wake up, take it, and go back to sleep, because that's going to lead it to be more likely to get stuck there in the esophagus. Okay, so again, they're going to get a lot of heartburn-like symptoms because of that, and so that's why we want to make sure they're upright. They take it, just a glass of water, and they should be good. Yes, ma'am. I would usually at least separate out by 30 minutes or so, or if they've eaten in the recent past, at least a couple hours, like maybe 2 to 4 hours or so, to make sure that there's nothing there in the stomach. This is why we make sure they try to take it when they first get up in the morning, because that's when they're fasted, and that should be helping with the bioavailability. One kind of rare thing you may also see here is just osteonecrosis of the jaw, so you do have to worry about that. There's been cases of like breaks that have happened because of that, so it's a rare side effect, but it's certainly notable with these ones. It's like a good board style question you should be aware of, right? So as I mentioned, just take it with a glass of water, nothing else, typically 30 minutes before consuming any other foods or liquids to give it time to actually absorb there. If patients, you feel like they're not getting the efficacy they need out of it, maybe they're still finding their bone mineral density scans are not looking good, they're taking it like they're supposed to, but they're not really getting as much bioavailability as you want, that's when you can consider switching them over to IV therapy, right? With that zoledronic acid, just going for one-time yearly infusion, and then you're done at that point, right? If that's not working, those again are kind of your gold standard bisphosphonates. If that's not effective, you can try switching over to a couple of different agents here. So for this first one here is called Denosumab. Obviously, you know what about this drug just off the name? It's an antibody. Yeah, it's a monoclonal antibody. So this is actually binding up this rankle protein. Basically, rankle normally binds to the rank receptor, and that actually stimulates osteoclasts to develop, right? So by binding up that rankle protein, you prevent the receptor from being activated. Osteoclasts are less likely to actually go to maturation. Obviously, because it's an antibody, it has to be given via injection, so this will be a sub-Q one they'd give, and dosed every 6 months or so. So again, a pretty long half-life, which is nice from that standpoint from compliance. There is some clinical concern. The thought is because normally, you know, the calcium that's in your bone, it's not completely static, right? There should be that balance between osteoblasts laying down new calcium and osteoclasts taking it up, so there should be some turnover. There's some concern over if you're suppressing that pretty significantly, there could be long-term complications. We don't really know at this point, but that is a theoretical concern. Another one I have here is calcitonin. Not commonly recommended for osteoporosis because it doesn't really help. We don't have enough clinical evidence to show that it prevents all types of fractures. This one's actually better for just vertebral fractures, but not hip, right? So there's little things they'll see there in the clinical trials. This is more oftentimes used for hypercalcemia with patients like Paget's disease and things like that. But it's actually going to be mimicking a portion of the parathyroid hormone itself. So it actually has a similar amino acid sequence to one end of that. And so basically it helps to suppress the activity of parathyroid hormone overall, right? Because once the parathyroid senses that, hey, there's enough PTH around here, it will help to shut off release there. Other things to note, it is available intranasally only, so it's a kind of a unique dosage form that you don't see too often. Anyone know where this comes from? So again, I like to point out weird animal or plant origins for drugs. This actually comes from salmon sperm, of all places. Again, whoever the scientist was that figured that out, maybe they had too much time on their hands, I don't know, but thank goodness they figured it out, because now we have calcitonin that we can use. We'll talk a little bit more about this later on in endocrinology at a later section. Another one here we have called teriparatide or Forteo. This one's going to be for patients, again, who have failed bisphosphonate therapy but are pretty high risk for fractures here. I'm sorry, I misspoke. So calcitonin is not the same as PTH, the amino acid sequence. I don't know why I was confused this morning, but which most like you guys probably are most mornings on Fridays, right? But regardless, I'm sorry, calcitonin it's a natural product that we produce ourselves, but we can give exogenous supplementation, and it actually helps to shut down PTH release there. So it's kind of the natural opposite acting hormone to PTH there. Teriparatide, as I was saying earlier, it actually looks very similar in terms of the amino acid sequence. It's a portion of it, of PTH, and so it actually helped to, again, decrease further release of PTH. So it helps to kind of shut that down. Again, typically not going to be as effective as your bisphosphonates will be. And again, issues here we worry about is actually stimulates osteoblast activity, and so they worry about having unopposed action. They're actually leading to bone cancer. So they actually say don't even take it for more than 2 years, because you can end up seeing a higher risk for cancer there. So that's, again, for really just high-risk patients, if the bisphosphonates are just not an option for them. So looking at this, you can basically see that for majority of patients here, depending on what their scans are looking like, you see calcium and vitamin D are always going to be the first stop for most of those patients there. And again, if they have bad kidneys or bad liver, what do? Give them the activated form, which is calcitriol. Okay, so you're going to give that if need be. Obviously, it's more expensive, but if you can get away with just normal calcium and vitamin D, then you're good. At that point, once they have a high enough risk, this is when you're going to consider adding on your bisphosphonates, right? So depending on what their fracture risk is looking like, what their scans look like, and again, ideally, we like to prevent this osteomalacia from developing if possible, so earlier starting is better typically. Start a bisphosphonate. If that's not working, then you got to kind of go to your second line agents, all of which are not going to be as good. So teriparatide or calcitonin or denosumab, probably denosumab first in a lot of cases there, and just see how they work, right? Ideally, though, if the oral bisphosphonates are not going to work, then switch over to that zoledronic acid. That's probably your next stop in a lot of cases. Okay. Make sense? Hopefully. All right. Let's talk about gout. What is gout? So it is hyperuricemia leading to precipitation of uric acid crystals. Where? In the joints. Yeah. Which one do they talk about kind of classically? What's so great about it? It's just fine toe. Okay. Anyway. Why do they call this the rich person's disease? Okay, so alcohol, do only rich people have alcohol? No, not HTs necessarily. Where do you get a lot of uric acid coming from? From meat, yeah, absolutely. So degradation of purines found in meat, right? Because all that meat, all that muscle has DNA in it, and those purines get broken down, and eventually will turn into uric acid, right? So back in the day, they used to call it the rich person's disease, because those were the only people that could afford meat at the time, right? Alcohol will certainly exacerbate this too, though, so that is going to be a component as well. I've never seen those old pictures, like those really old school pictures of like the little devil. It's like got a pitchfork and he's poking the guy in the toe. Look those up and you kind of get a feel for like the type of people they were talking about that would classically kind of get gout. But anyway, so again, we're having these uric acid crystals that are precipitating out in the joint, and they're quite painful there, right? And they also elicit a inflammatory response as well. Not only that, but you also can get nephrolithiasis if these are going to be precipitating out in the kidneys as well. That can cause interstitial damage, can lead to renal disease in the long term, right? So usually what we're going to find is that the issue here is either due to overproduction of uric acid, which would be either we're giving too many purines in the diet potentially and causing that breakdown. But it's not just the meat that you're consuming. It can also be from cell turnover, right? So we actually have something called tumor lysis syndrome, where patients with say for instance like leukemia, they get chemotherapy and kill off all those cells, but they're releasing all that DNA and it gets metabolized into uric acid. That can cause really severe hyperuricemia. So it's either an issue of overproduction or it's an issue of underexcretion, right? So either due to things like dehydration, could be related to poor kidney function, could be a lot of different things that are there, right? And so our goals are either to, one, treat the acute attack that's happening, right? Say they present to the ER and they're like, my great toe hurts so bad, I need some help, right? You check their uric acid level and it's sky high. You need to treat that acute attack. And then we're going to look at ways to try to prevent that from occurring. If they have recurrent episodes, say more than a couple times a year, then you go ahead and start them up on therapy to help prevent an attack from occurring there, okay? So we are urate lowering therapy. So usually what we're going to try for these patients first, NSAIDs tend to be the go-to in a lot of cases there, so not one NSAID's better than another, but say if they're in the emergency room and I have an IV, what can I give them NSAID-wise? Toradol, yeah, Toradol is going to be a really good option for those patients there. Some patients also benefit from corticosteroids, maybe like a short couple days worth of prednisone or something like that can also be quite beneficial. And there's a new one we'll talk about called colchicine. And colchicine actually works kind of similar. We've covered chemotherapy already, correct? Hopefully we did, right? If you remember, there are certain drugs that work to prevent the microtubules from actually causing replication of the cells. Remember, they inhibited mitosis, like your zinc alkaloids, things like that. Colchicine actually works kind of similar to that, and we'll see how that's going to work in just a few moments, right? But it works on those microtubules, essentially. Typically, earlier, you can start them off once they're symptomatic, the better. And again, they're going to be, especially if they have recurrent episodes, oftentimes they'll have scripts for as needed, colchicine or Celebrex or something like that to treat their pain once it actually develops there. Usually it's just one joint, but you can have people who will develop multiple joints there when they have their gouty attacks. Anyway, we talked a lot about NSAIDs. We know the risk with that. Typically, corticosteroids can either be used by themselves or in conjunction with the NSAIDs, and usually it's going to be just for a short couple days worth. It's not like something they need to be on chronically. You can try intraarticular corticosteroids, especially if it's just one joint that is being affected. That can certainly try that. If it's more than two, then you're oftentimes want to just go ahead and give systemic therapy at that point. If it's going to be more than a week, remember you got to taper. Why is that? Or the adrenal gland shuts down production after a while because it says, hey, we have enough steroids around here. Adrenal insufficiency is what you worry about with abrupt withdrawal if it's more than a week, right? So colchicine, as I mentioned, is an antimitotic drug. It prevents those microtubules from forming. So not only will it help to suppress those immune cells a little bit when they're having inflammation, but also it helps with things like the locomotion of neutrophils to the site of inflammation and things like that to try to prevent the inflammation. So it works pretty well for that. You tend to find that it's very tough on the stomach. And the old dosing we used to use for colchicine was basically you keep taking tablets until you throw up, and then that was it. And I was like, well, that's kind of a weird way to dose something, but that's what they did for a long time. And so nowadays I'm seeing less of this being used, oftentimes more NSAIDs and corticosteroids, but it can still be effective for some patients there. Obviously, it's going to have a lot of dose-dependent GI effects because if you recall, what were some organ systems that were really hit hard with chemotherapy drugs? GI, right? Because those cells are slow dividing, rapidly dividing, right? So you can see a lot of GI effects because of that. You also see neutropenia that can develop potentially. You also see neuropathies that can develop here. Well, it's a pretty harsh drug. So again, but it's been around for a long time. It has a pretty good track record in terms of efficacy there. Again, depending on the patient there. So for instance, if I had someone who had a history of, say, GI ulcers, maybe I don't want to go with an NSAID right out the bat. Maybe we'll try something like, say, colchicine potentially. You have your options there, right? Typically, it's a pretty severe pain, then you can use a combination of the two. So maybe using something like Toradol plus corticosteroid is a good option if they're having very severe issues. And then again, if they're having recurrent attacks, this is when we're going to talk about urate lowering therapy that's going to be able to help prevent the attack from occurring in the first place. So how do we do that? How do we maintain lower uric acid levels? Well, one, if we could limit alcohol intake, that's going to be beneficial, right? And remember, does alcohol leave you nice and refreshed and hydrated? No, it causes you to be dehydrated, right? And remember why? Yeah, it inhibits ADH release, right? So that's why you pop the seal, so to speak, and have to urinate so much, is because you have less ADH holding on to all that water. So you get dehydrated. That can also help with the uric acid to precipitate out. And also you can find certain medications can also lead to hyperuricemia as well. So a lot of our diuretics can do this. Things like niacin can do this, and also even low-dose aspirin can do this as well, right? So a lot of reasons why medications can actually help raise this up. Obviously, if you can help them control with their diet as well, things like red meats and whatnot have a lot of purines in them, that can also be beneficial. So typically, if we're going to start someone on urate lowering therapy, it's going to be for those recurrent attacks that has maybe more than 2 in a year. We'd go ahead and start them up on urate lowering therapy here. We can do this 2 ways. We can either decrease the actual synthesis of uric acid. This is going to be our xanthine oxidase inhibitors, and then we can also increase the excretion. 9 times out of 10, though, you're probably going to be going with something to decrease the actual production thereof, and I'll talk about why that is in a moment. So this is how we break down nucleic acids into eventual uric acid. It's a pretty complicated process here. So know this pretty well for the test. I'm just kidding, no. The main thing I want you to know from this, though, is that while it is a complicated process here, ultimately, xanthine oxidase is an enzyme that will eventually convert this over into uric acid. So if I can inhibit this process, you'll end up with just a bunch of hypoxanthine, which is much more water soluble and it's easier to clear. So by introducing something that will inhibit this enzyme, we get less uric acid being produced overall, which is going to be helpful to these patients here, right? Basically, we have two agents that fall into this category. We have allopurinol, which is the older of the two and has been used for a really long time. It's called Xyloprim. This one does have some side effects associated with it, though. You see things like leukopenia, GI upset seen with this. Also, you can see risk for things like Stevens-Johnson syndrome, toxic epidermal necrolysis, so you do have to monitor for rash. Anything like that would be a good indication to stop taking the drug right away, right? A newer one we have now is called febuxostat or Uloric. This one is better tolerated than allopurinol overall, but it's also more expensive, so you see fewer patients are going to be on that, right? Another way I could do to get rid of the uric acid would be to use what I call a uricosuric drug, which means I can just pee out more uric acid. And so we used to use this drug called probenecid. Probenecid actually got its start back in the day when, nowadays you have like synthetic means of producing things like penicillins and cephalosporins. But back in the day when we just, got it from mold essentially, like, it was very hard to produce. And so we wanted to extend the half-life of the drug. And so we actually gave them probenecid to prevent them from secreting the drug into the urine. That way they hold on to more of it, the half-life was longer, and it could treat that infection better. Probenecid also helps you to pee out more uric acid and help to get those levels down. However, what could be a potential risk with that? Well, if I'm getting more uric acid into the renal tubules, you see nephrolithiasis could develop because of that, right? So that is certainly a risk there. And if they have renal impairment, you definitely don't want to use this drug for those patients as well. So most of the time, most patients will be on allopurinol, maybe febuxostat. If that's not sufficient or not tolerable, then maybe probenecid can be used occasionally. This last drug I'll talk about here is called rasburicase. We use this very rarely for patients who have extremely high uric acid levels, usually as a result of chemotherapy. So for instance, we just had a patient just the other day, we were talking about whether or not to use rasburicase because they had leukemia, they got chemotherapy, and the uric acid levels were skyrocketing essentially. Basically, this is a recombinant form of the enzyme that just basically cleaves uric acid entirely. So once you form the uric acid, this will basically come in, cleave it into more water-soluble formulations, and then you don't have to worry about it so much. So very effective. Problem though is like quite expensive, thousands and thousands of dollars for this medication here. So we actually have like really strict guidelines on who can get it. Can they use allopurinol instead? Is it a life-saving kind of thing? That's when we kind of bust this out. Do you worry about patients with G6PD deficiency? This can actually induce hemolysis and methemoglobinemia, so you do want to be cautious with that. So, and basically, again, most patients are going to start out on uric-lowering acid therapy, go with a xanthine oxidase inhibitor, most of the time allopurinol. That's not working, switch them over to something like probenecid. And again, very rarely would you ever use rasburicase. Probably if you're working in oncology, that's where you're going to see that used most often, right? Okay, any other questions on that? If not, let's jump into the neurology section. So we have this week and we have next week. And then the following week we have the test, right? So I'm going to see what we can get through in terms of covering all of this. So let's talk about neurology. Have you guys covered any neurology stuff in your medicine courses yet? It's okay. You will get there. Let's talk about epilepsy first, though. What is epilepsy? Seizures. Okay, what's a seizure? You're like, that's why I came to school to learn, buddy. Why do you keep asking me all these questions? So essentially, just like an arrhythmia is an aberrant electrical signal in the heart, we have the same thing going on in the neurons of the brain, you get a seizure, right? So, and actually, some of the things we'll find here are very similar in terms of mechanisms of action, right? So what was a big way we could stop, say for instance, an arrhythmia? What kind of mechanism could we use? What kind of channels could I block? Sodium channel blockers. Actually, we can do the same thing in the neurons and actually stop seizures, right? So you're going to see some parallels between arrhythmia management and epilepsy, right? Similar, just like we talked about with antiarrhythmics, that any of them can actually cause an arrhythmia. Guess what any of these antiepileptics can do? Cause a seizure for the most part. Yeah, so we'll look at that as being some risk there. So, and there's several different forms of epilepsy. I mean, neurologists can go through all the different types, and it gets very detailed. Fortunately, though, you're going to find a lot of our drugs are pretty broad spectrum. I mean, they treat a lot of different types of seizures, so you don't have to get so much in the weeds in terms of talking about delineating the different types of seizure disorders. One thing that is also really important to talk about is also called status epilepticus. If you work in the ER, you might see this occasionally. So, anyone know what the status epilepticus is? Yeah, so someone has a seizure, and that seizure terminates. Does the patient like kind of go right back to their normal baseline mental status? Not typically. They're kind of zoned out a little bit. I mean, the neurons are just firing off like crazy, and all of a sudden everything's kind of slowed down again. So we call that the post-ictal phase, right? So that period before they kind of go back to the baseline mental status. So if you have continuous seizures that don't stop, or if, say, you never come out of that post-ictal phase before you go back into the next seizure, that's called status epilepticus. So it's a really big concern, especially like ER, ICU settings there where we're trying to treat those patients. Because again, what are some problems when a patient's having a seizure? Yeah, they may stop breathing effectively, right? They may not protect their airway very well, so they could aspirate things. They're incontinent. There's a lot of issues there. So again, when they're seizing, often what we're really worried about is like, when are they oxygenating, right? You take care of your ABCs, and so that's a big risk. So a lot of these patients end up getting intubated because of the fact that we need to make sure we can oxygenate for them because they're still seizing, right? There's a lot of reasons for patients to develop seizures, so it can be anything from like head trauma, could be due to just their genetics, a lot of features about that. We also find that drug use can also be a big player here. And anytime you have a patient, especially like an adult patient with a new onset seizure, you should always consider that medications may be involved here. A lot of medications, either the presence thereof can cause seizures, or maybe even withdrawal from certain medications can cause seizures too, as we'll see in just a little bit. So, and when I say AEDs, that stands for anti-epileptic drugs. So we'll talk about those in more detail here in a second, right? Anyway, so what we're looking at here is these neurons are hyperexcitable and they're firing off inappropriately. So in general, how we're going to try to affect that is to try to decrease their activity by keeping them from firing off action potentials, right? So there's several ways we can do that. So for instance, if you recall the action potential cycle, we mentioned that you can block sodium channels, right? So if I block a sodium channel, you never have that depolarization. That's one way to do it, right? What's also like the main sort of inhibitory neurotransmitter in the brain, though? GABA, right? So GABA is going to be also playing a really big role here as well. GABA is the brakes on the system. When you have GABA activate its receptors, it actually opens up chloride channels, right? So chloride is negative, right? Flows into the cell. What does that do to the electronegativity of that neuron? It makes it more negative, and thus it makes it harder to have an action potential, right? We're hyperpolarizing the cells such that they have a harder threshold to clear in order to have a seizure, right? So you guys ever heard of the seizure threshold before? These will be things that help to increase that threshold, make it more difficult to have a seizure, right? So GABA is a big one that's going to be playing a role here. The opposite of GABA, and in fact what turns eventually into GABA, is called glutamate. Glutamate's very hyperexcitable, right? It actually allows for things like calcium to flow into the cells. It has a lot of different receptor types, but it's very important for causing excitation. So there's a balance between GABA and glutamate, and if you disbalance that, that's where you end up having seizures in a lot of cases there, okay? So remember, what normally maintains the electronegativity of the cell, kind of that resting membrane potential, what maintains that in the neurons? What did it in the heart? Your baseline resting membrane potential. Remember the sodium potassium ATPase pump, right? Same thing is for the neurons, right? You find the action potentials here are going to be very almost identical in terms of their physiology, right? And so again, you're going to find that there also needs to be a balance of that as well to make sure they're maintaining the right electronegativity such that the neuron can fire when it needs to, and it's not going to be firing off inappropriately when it doesn't need to, right? Also, remember we talked about refractory periods in the heart? What's a refractory period? Or yeah, it's like a period where the cell cannot fire off again, right? So we have the same refractory periods that happen up here in the neurons as well. And so typically, again, when you have a seizure, the refractory periods are too short. We can give them things to actually increase that refractory period. And that's where a lot of our medications are also playing a role here as well, right? Anyway, so in terms of diagnosis, I mean, a lot of times it's pretty easy to tell when patients are having seizures, but there's certain types where it can be more difficult, right? So you guys ever heard of an absent seizure? Basically, you ever have like someone like goes just like into a staring spell, they just kind of stop and then come back into it?
Kids do something.
It depends. I mean, anyone can have an absent seizure, but I mean, usually like, you guys have absent seizures during my class. I can see a lot of times, but But most of the time, if they're having a general tonic-clonic seizure, like you're going to know about it, right? It's pretty easy to tell from there. But the big thing is to do the history to find out why are they having that seizure in the first place, right? Sometimes it's medication non-compliant, sometimes it's medications causing, maybe illicit substances, infection, all these things. So you typically have to do a pretty good workup to kind of find out why the patient's having the seizure in the first place. Sometimes it's just idiopathic and we don't have a good reason to point to, right? Our goals, though, are to decrease the number of seizures that they're having. You will find that some patients have such intractable seizures, maybe due to things like ischemia, during, let's say, childbirth or something like that, where they'll never get down to having no seizures at all, right? That can be very debilitating, but it's one thing we can do to just try to get the number of seizures they're having down if we can. Other things to make sure we're kind of addressing quality of life, make sure a lot of times the side effects are going to be pretty significant with these anti-epileptic drugs here, so that's also going to be a big concern. Because again, some patients can go a long time between seizures, and so most often when you're giving them anti-epileptic drugs and you say, well, are they working or not, it's hard to tell because they're like, well, they've had a seizure anyway, right? So in those cases, there's kind of like the elephant spray example I used before, right? So it's kind of like that where, they're definitely having side effects. They definitely know they're having side effects because it's affecting them, but they don't know how efficacious the drug's going to be. So that's where we can do things like therapeutic drug monitoring, make sure levels are good, and obviously they're going to be keeping track of how many seizures are actually happening to document that kind of efficacy. So also consider things like age can be playing a big role in terms of how they're processing the drug. Remember, like kids, they have different ways that their liver will mature over time, such that when you're looking at something like phenytoin, which is an anti-epileptic we're going to mention here in a little bit, when they are very young, say 6 months to 3 years, they metabolize this stuff like crazy, like very, very fast metabolizers, such that they need 8 to 10 mg per kilo per day just to get good levels. Well, as they mature, you're going to find that slows down to where by the time they're 10, they only need maybe 6 to 7, right? And so again, you're constantly having to go back and readjust that based on their maturation, and it can be very drug dependent there. But also think about their ability to comply with their medical regimen in the first place. Like if you're prescribing an expensive anti-epileptic drug and they can't afford it, and obviously they're not going to take it, right? Or we run into problems a lot here, being in Florida, being in Orlando, being a travel hub. We get a lot of kids coming from out of state, a lot of people traveling here, and maybe they forgot their medications, right? So now they're non-compliant, and now they come in with seizures. So we get that quite a bit, especially with these a lot of Make-A-Wish kids that are very medically complex, or they get stressed out with all the travel and being at the parks, and they develop seizures and they come in. So a lot of reasons for that to occur. Anyway, so our steps in therapy are one to make sure, did a seizure actually occur? Do patients ever fake seizures? Why would they do that? To get meds, absolutely, because some of the meds here we're going to find are potentially addictive, right? We'll talk about some of them being controlled substances, right? We used to do a thing, we'd have the patients would come in with, we call them pseudo seizures. So if you ever see that term, that's usually what we mean, because patients don't know that means that we think they're faking. But we would have patients who would have a seizure, quote unquote, and then they'd be in this post-ictal phase where they're unresponsive and they wouldn't talk to us or anything, and so they look unconscious for all external purposes. And so we would do something called the hand test and then see were they actually with it or not. And so anyone ever heard of the hand test? Basically, you have them laying down in a bed, you have them raise their hand over their head, and you drop it. And so presumably, if they're actually unconscious, their hand will hit their face, right? What do people who are conscious do? They move their hand, right? So then you know they're probably faking it, right? So little tricks like that you'll pick up to see, okay, is this person legitimate or not? But if we assume that a seizure did happen, we got to say, well, what type of seizure was it, right? So for instance, if it was a febrile seizure in an infant, well, that's a pretty easy treatment. You get the temperature down and that should stop the seizures, right? Or is it something else entirely in those cases there? So again, and the question is, like, do we always start pharmacotherapy? Not necessarily, especially if it's like an obviously like reversible cause. So if, say for instance, the patient was doing a bunch of amphetamines and that caused a seizure, well, if they stop doing the amphetamines, then presumably they're not going to have the seizure again, right? And then looking at, say, which drug is most appropriate, how are we going to dose it, how are we going to monitor its effects. We'll talk about that as we get into the drugs. So our anti-epileptic drugs, typically you're going to find that none of these are going to reverse the reason why they're having a seizure in the first place. So they just have an ectopic portion of the brain that's going to generate seizures. They're just always going to have that. Some people may grow out of seizures, but oftentimes it's going to be a lifelong condition for them. So these don't modify anything about the disease itself. It's just going to actually treat and make sure that the seizures don't occur in the first place. Most patients will be fine just with one drug. very often you're going to find a lot of patients will require more than one drug, maybe 2, 3. I've had some patients, these really like complex kids, maybe on 5 or 6 drugs just for their seizure disorder, and they're still having multiple seizures a day. It can be very, very debilitating from that standpoint. There's other things as well. Sometimes surgery, if you can take out portions of the brain that's actually causing the seizures, that it can be done rarely. Even a ketogenic diet can help here. So why would we do that? What is a ketogenic diet? So you cut out what out of your diet? Carbs, right? So you're in a very low carb state or almost no carb state, and then what does that do? You generate ketones, because why do you generate ketones? You used all your glucose, so now what are you using for energy? Using fat, right? So you're switching over to oxidizing all those fatty acids, and that produces ketones, right? Well, that also produces an acidic pH because of the fact that all these acids are being formed in the blood, and so typically you find the pH will lower a little bit. That also actually helps to increase that seizure threshold, makes it more difficult to have a seizure. So by putting these kids in an acidotic state mildly, you actually can hopefully treat their seizures as well. So sometimes we'll have kids that will come in. If you ever see anyone who has a dextrose allergy, you think, oh, that's silly, like you don't have a dextrose allergy, be dead, right? Because they wouldn't have any blood sugar, they'd be reacting to it. That's usually our indicator that they are on a ketogenic diet, right? And the problem, why do you think it's a big concern with pediatrics from like a pharmacy standpoint?
Syrup flavorings for medicine.
Yeah, so how do kids take their medications? Can they take big tablets? No, they take a lot of liquid preparations. What do we put in the liquids to make them taste better? Sugar, right? So there's all kinds of sugar products you have to worry about. And so we just had a kid the other day who's coming in, they're getting admitted, and we had to go through, we had to look at all the medications and make sure that what we're giving them is not going to knock them out of ketosis, because you can find out there's a lot of sugar in different products there. And so for instance, like, one of the tablets we had some cornstarch in it, and cornstarch can be converted over into glucose. And so that was enough to where they decided to go with a different formulation just because of that, right? So just even tiny amounts of carbs can really throw them off. So anyway, different options there we're going to have, but we're going to focus on the meds, obviously. So also things to keep in mind, what are the goals with the patient? Are you trying to eliminate seizures completely, or just maybe reduce the number of episodes they're having? What kind of adverse effects are going to be tolerable by them? And then what kind of monitoring are you going to be doing? We'll also focus a lot on mechanisms of action, because when you combine different meds together, you want to make sure you use multiple meds of the same mechanism. No, you do different mechanisms, right? We want things to be complementary to one another, and so we're going to look at some ways we can do that. As we mentioned, monotherapy is going to be good for most patients. We'll start out with that, and then depending on how they're getting control of their seizures, we may add on other things, right? Either we may switch that medication if it's intolerable from side effects, or just add something else on if it's just not all that effective. Generally, start low and go slow is going to be the name of the game here. Gently work them up, because most of these meds, as you might imagine, by inhibiting those neurons from firing, what do you think is the main side effect of a lot of these? If your neurons aren't firing, confusion, sedation, right? A lot of these are going to be very sedating medications. It can cause ataxia, it can lead to falls. I mean, they're slowing everything down, right? So again, imagine like you before you have your coffee in the morning or whatever, like just everything kind of gets slowed down to varying degrees depending on the drug here. And so that's going to be big things for monitoring for, right? But there's also a lot of other side effects we'll see as well. And then again, if we're switching up drugs, obviously, different mechanisms here, we've got to know what our options are from that standpoint. So here are the main groups of drugs we're going to talk about. The more detail I go into on a particular category or particular drug, it's probably going to be more likely for test questions. Some of these we don't use all that frequently, so I'll kind of mention them briefly as we get to them. But these are mainly going to be the big ones we're going to talk about here: the sodium channel blockers, calcium current inhibitors, and also our GABA enhancers. So those are going to be the main 3, but we'll see there's a couple other ones here. And sometimes medications may have multiple mechanisms, and we'll talk about that.
Does dopamine have any role
Not I'm currently aware of, but for instance, like dopamine may be converted over things like norepinephrine, and norepinephrine can certainly lead to seizures. So for instance, if you have someone who's like, say, doing amphetamines or cocaine or something, you can see seizures because they're basically releasing all this norepinephrine that can definitely kind of increase stimulation and cause seizures to develop because of that. So there could be some link with that depending on the substance for sure. Anyway, so getting into the different classes here, so we'll talk about our sodium channels first. Remember that we have kind of 3 states that the sodium channels will be in. They have the inactivated state, or the resting state, where basically they are waiting for a signal to come along to cause an action potential. Once they're active, they're open, and sodium flows out or into the cell. into the cell, right, because it's along the concentration gradient. That causes the depolarization here, right? Remember that phase 0 depolarization that happened in the heart? We have the same thing happening here, right? And then it goes into the inactive state. That's basically that refractory period. It's a period of time where the sodium channel cannot open again until it returns back to the resting state there, right? And so again, by blocking the sodium channels, preventing sodium from coming in, you may not actually have that full depolarization occur, and thus you may not propagate that action potential, right? So here you can find that different medications may work on different parts of the channel. So for instance, something like phenytoin may work on the inactivated state preferentially to prolong that refractory period, thus preventing that cell from getting back to a resting state to fire off again, right? And so we'll look at the different medications and where they're working at, but these are good pictures to kind of refer back to. Our calcium channels, we have different varieties that also exist. So remember, we have like L types and T types and things like that. Typically, we're going to be focusing on the T type calcium channels. Remember when we talked about cardiovascular meds, which one they worked on? Yeah, they worked on the L type. These are going to be T types. So we actually find that some of them can be really useful for different types of seizures. So for instance, blocking sodium channels is good for a lot of different types of seizures. Here, by affecting calcium channels specifically, we have one drug that just does that alone. And that's really good for those absence seizures, right? So we'll mention that as we get into it. Here you can see an example of blocking those calcium channels. Normally calcium is going to be stimulatory, just like calcium causes muscles to fire off. The same thing can happen here where you're causing excitation of the neuron. Blocking that will help to prevent that action potential. Now GABA comes in two varieties in terms of GABA receptors. We talked about GABA B a little bit. Anyone remember what drugs they worked with? The muscle relaxants. Yeah, I remember what was a big side effect of the muscle relaxants? Drowsiness, sedation, dizziness, etc. Right? So that kind of makes sense because they're working on GABA, which hyperpolarizes those neurons. Here we're going to focus mainly on GABA A, right? GABA A, when it opens up, allows chloride to flow in, causes the negativity of the neuron to get even more negative, and thus makes it more difficult to have that action potential, right? Say maybe resting at negative 70 millivolts, maybe you go down to negative 90, right? And that makes it more difficult to have that seizure, right? This is going to be one of like the mainstays for acute treatment of seizures. So if I have someone who's like actively seizing, this is mainly going to be the mechanism I'm going to be going with, trying to enhance GABA to get those neurons as negative as possible to prevent them from firing off, as we'll see in just a little bit. As I mentioned, GABA B is more oftentimes linked to like potassium channels and things like that, but GABA A is what we're mainly going to focus on here, and chloride. There's a couple ways we can affect the system. So we can either help to enhance how much GABA we're producing. Once that GABA is made, we can try to help with how well it works at the receptor itself. And we can also help with the actual either reuptake or the actual breakdown of GABA. So there's different ways we can modify the system to try to make sure that we have as much available as we can. So for instance, by inactivating something called GABA transaminase, you can prevent the breakdown or metabolism of it. Thus, there's more available to interact with those receptors. Thus, more of them can cause that chloride to flow in. As I mentioned with the acute seizure management, this is oftentimes going to be the most effective way to do it, is by actually enhancing the GABA to work better, right? So for instance, I can give them a benzodiazepine, something like Ativan or lorazepam, and that actually allows GABA to bind more easily with the channel. The easier it binds, the more likely it is to open up and flow in, right? Or like our barbiturates are also going to be another class we'll talk about a little bit that does something similar. So here you may imagine the presynaptic nerve here. It has these channels will be full, or these vesicles full of GABA. Things we can do to try to affect that, includes producing more of it. We can do things that help prevent the breakdown thereof. But once it's out and actually in the synapse here, this is where our benzos and our barbiturates are going to help to allow it to bind more easily, allow it to open more, and again, hyperpolarize those neurons. It'll make more sense when we get into the specifics of the drugs that we get to them. Glutamate is also going to be an important player here. So we mentioned glutamate is excitatory or inhibitory. Very excitatory, and by inhibiting this, you're going to be able to, again, decrease that excitatory sort of activity there. We'll get into more of these different types of drugs, and they can have wildly different effects. So for instance, depending on the receptor that they work at, you may find really interesting things like ketamine. Anyone ever heard of ketamine before? The name for it is another name, a slang term. Special K is a big one. You go down the K hole, as I mentioned. I know you guys are good kids. You don't go and associate with people that know about K holes and things like that. Anyway, but ketamine actually blocks certain types of glutamate receptors, and it causes this dissociative anesthesia. Basically, they have an out-of-body experience, and you can actually have reduce fractures or do procedures on patients, and they're not even aware of it, right? Because they have this anesthesia that happens. A lot of different things you can do with glutamate receptors. Just know there's a lot of different types of channels, and mainly though I'll kind of mention them as they come up. NMDA receptors are going to be kind of the biggest group of glutamate channels we'll talk about, and that'll be our biggest target for our medications here. Now, the drugs themselves, I'm not going to cover every single one of them that are out there. There's new ones that are coming out with some regularity, but I'll focus on the main ones that we use kind of day in and day out, the most common ones you're going to run into here. The problem, though, is it's really hard to say what is the best one to start a patient out on, because it's hard to do head-to-head trials where you actually compare one to the other. So most of the new ones coming out they're approved for add-on therapy to other things, but not necessary for monotherapy by themselves. Because again, when you're doing clinical trials, you have a patient with a seizure disorder, and you can either do like a placebo-controlled trial? Not really, right? Because again, it's hard. You want to do that. You don't want to withdraw seizure medication from a patient so they have a seizure, right? If you're in the control group, so it's hard to do those kind of trials there. And so oftentimes they're good as add-on agents, but the tried and true ones we have, we'll talk about. Those are most often used as kind of monotherapy by themselves. Anyway, so getting into the medications, the first one we have here is one of the oldest ones we have. It's called phenytoin. And phenytoin, just to give you an example of that parallel between this and arrhythmia management, is that this used to be an antiarrhythmic, right? That was originally what it was used for, but they realized it was much better as a anti-epileptic medication, and so that's where it gets used most often. This one has a lot of issues with it, mainly because of the pharmacokinetics of it. So for instance, one thing, it's really highly protein bound, right? It's about 90% protein bound. So what happens if I have something that comes and kicks it off of the channel, or off the protein? Remember, what's active, the bound protein form or the unbound form? Remember, if it's stuck to albumin, can it interact with your neurons? No, right? So it's the free form that's actually the active one. If I have something come along and kick it off the albumin, the free fraction goes up, right? And then the drug is maybe more effective, but also more likely to cause toxicity, right? So there's a lot of protein binding interactions that can happen here. Patients with low albumin levels can also have a higher free fraction. So even though their level in the blood looks normal, they have way too much free drug, and that can cause some toxicities you may see there. And then you'll find that the kinetics are also going to be a big thing with a lot of these drugs. A lot of these drugs tend to be modifying the CYP system, which I know that's your favorite thing to talk about. But you're going to find here that phenytoin can induce 3A4, it can induce things like 2C9, so there's a ton of drug interactions with these medications here. So anytime you're going to add on one of these or start a patient on one of these, make sure you do an interaction check to make sure they're not going to cause any big changes in their other medications they may be on, right? So a lot of issues here, but again, it's a really good drug. It works for all kinds of different types of seizures. It's good for either chronic management, or you could even use it for acute seizures in some cases there. So if I have a patient who's having a seizure and we give them a couple doses of Ativan, but they're still seizing, this may be a really good drug to go to as a second line there. So it's pretty effective. As I mentioned, sedation, lethargy, those are all going to be kind of the most common things you're going to see here. And they also tend to be, ataxia is a common thing as well. And they tend to be a big fall risk, especially if their levels are too high. So you got to be careful with that. Hirsutism can be another thing to be cautious or to be aware of that can happen here. And then along with gingival hyperplasia, right? So kind of unique sort of side effects. You got to have good oral hygiene to make sure you kind of keep those gums back, kind of at bay a little bit. Otherwise, that can become an issue. Phenytoin can also induce vitamin D deficiencies and can worsen osteomalacia if you have patients who are at risk for that. But again, as I mentioned, was a first-line drug for a long time. It's starting to take a little bit of a back seat, especially in pediatrics, mainly because of the side effect profile. We have some drugs, a little bit newer ones that are going to have more favorable profiles we'll see here. And then finally, the rash and risk for Stevens-Johnson. This is not going to be the worst one out of the anti-epileptics for causing skin issues, but this is certainly one you want to keep on your radar, right? So again, if they have any kind of like oral ulcerations, or they have any sort of rash or blisters or anything like that, have them stop the drug entirely, because again, the negatives of Stevens-Johnson's are going to outweigh the potential that they have a seizure in that short term, right? So looking at this, you're going to find that the dosing is pretty wildly different depending on the patient you're treating there, whether they're a child, an adult, whether they have other medications on board that could be affecting it. But again, looking at this, I'm not going to have you memorize the therapeutic range, but I at least want you to be able to interpret a level if I put one on the test, right? So I'll give you what the reference range is for this. But in a lot of cases, though, you can have patients who have a normal total level right? That's the total amount that's in the blood there. But if they have like a protein binding interaction, and having toxicities, you'd be able to tell that by getting a free level, right? So you can actually do a different test and see just what the free fraction is. That's going to be good for certain patients if they have a normal level, but they're either having too many seizures or if they're having toxicity. That way you can check a free level and see kind of what's really going on more clearly. Yes, sir.
So what would be the purpose of checking for levels?
Yeah, for a long time that was all that we had available to us was total levels. It was we didn't have any assays that could run a free level or any lab that could do it. And then for a long time it was a send out lab, right? So when I say send out, anyone know what that means? Yeah, I can't do it at the institution. I have to send it to somewhere else. So for instance, like we had to like send out like the Mayo Clinic, like they run every test known to man, or woman for that matter. And it was more expensive, took a long time to come back. Nowadays it's more available, and so, but if you don't need to check a free level, if they're not having any issues, it's just more economical to do a total level. So it just depends on the setting. Yeah, as I mentioned with the protein binding though, if you have anything that disrupts that, so if I have hypoalbuminemia, if I have renal failure, all these things can affect that, and then not to mention just drug interactions that can kick it off the protein. All that can definitely affect how much toxicity you're getting there, okay? Now, again, when a patient's having an acute seizure, what routes do you think I can use to give them medications? Having a tonic-clonic seizure on the floor, how can I give them meds? I could do IM, I could do IV, what else? Nasal potentially, good, what else? Rectal is going to be a big one, what else? Can I do oral? Why not? Aspiration's the big risk, right? So that's really the big thing there with acute seizure management. Oral route is not going to be available for those patients. You got to find something else, okay? So frequently if they're having seizures and they're in, say, they've been gotten to by EMS or they're in the ER or something like that, we try to go with parenteral therapy to treat them, right? So either IM if we have it or IV. Now, do you think it's difficult getting an IV on a patient who's actually having a tonic-clonic seizure? It can be tough, right? But you know, there's some exceptional nurses out there that can certainly get it. You have to be really careful with phenytoin by itself. The drug does not like to go into solution, and to do so, we have to add things like propylene glycol, and we have to increase the pH to something like 11. And it's a very harsh drug on the veins, causes thrombophlebitis. And actually, here's an example of something called purple glove syndrome. This is what happens when phenytoin extravasates. When I say extravasate, what does that mean? Yeah, if you blow a vein and it goes out into the tissue, it causes severe necrosis. And so, I mean, someone could lose a hand because of that. So in these cases here, it's really important to make sure you're using like a deep vein if possible, central line, right, where it's actually a line that empties out into the vena cava itself. That's going to help out with that. But it can be really harsh on the veins, okay? So to counteract that, what they ended up doing was producing something called phospheniton. Cerebex is the brand name for that. It's actually basically by putting a phosphate group onto the drug, it makes it more water soluble, and so that is going to be much better, much easier on the veins. You can give it IM now; it doesn't cause any of that tissue necrosis, and basically the body will cleave off that phosphate group, and then you just have phenytoin that can work as an anti-epileptic, right? Again, the question would be, well, why would you ever give IV phenytoin if you have phospheniton? Sometimes you have recalls, sometimes you have shortages, and so for instance there was a time where phospheniton, there's an issue where they would have like glass particulate that would actually come off into the vial, and so they recalled all the phospheniton, and they were like, okay, well here you can use phenytoin instead, and we're just like, well that's not great, because if you think about IV administration, someone who's seizing, think about kids, how big are their veins? They're pretty tiny, right? So this is one of those things where, like, you know, in rare case we'd have to give this IV, and we had to really make sure that we had a good line established, make sure it's as deep as possible, and not going to cause this purple glove syndrome. So it's another thing you may see occasionally. Yes, ma'am. Yeah, a lot of these tend to be teratogenic. So we'll mention one more specific a little bit later on. But yeah, so that can be really tough too, because if you think about it, when is drug exposure during pregnancy sort of most critical? That first trimester, right? Because also when the organogenesis is occurring, and then also consider the fact that when do a lot of women find out they're pregnant? Like, do they have like these little cherubs come down with a big sign that says you're pregnant? Like, no, they may not know until much later, right? Maybe past the first trimester, right? So you could have all this drug exposure occurring. Not only that, but think about the fact that phenytoin inducing those CYP enzymes can increase metabolism of estrogen. So maybe they're taking their oral birth control, they're taking with phenytoin, those levels of estrogen drop down, they ovulate, they get pregnant, right? So again, that's a big concern. So making sure they have appropriate birth control. Sometimes we'll use alternatives like intrauterine devices. We can use things like progesterone only, ways to get around that. But yeah, a lot of these tend to be pretty teratogenic for sure.
Is it mandatory to have someone who's childbearing age beyond some kind of
That's a discussion with the provider, right? So, if you have a patient that says, well, I don't have sex, so that may be truthful, maybe not, right? It can be really tough. So, for instance, we have at Nemours, all girls of childbearing potential will get checked for a urine HCG before surgery, right? Even though they say, well, they're not having sex, and we check down to like 9, right? So even though they say they're not having sex, the parents could say that, but that may not always be the case, right? So yeah, it's definitely a discussion between the provider and the patient there, but.
So it's not as prevalent like Accutane?
Not like Accutane, yeah. So it's not going to be as nearly severe as that, or at least it's not been to a point to where the FDA decided they needed a REMS program for that sort of thing, yeah. And plus, if you think about it, there's probably, I guess I don't know the actual prescribing amounts, but if you consider also Accutane as being more of an aesthetic kind of drug versus something like phenytoin as being like more life-saving, more life-critical, so to speak. There may be some differences there too. So I don't know. Yeah. Anyway, so I wish I had more time. I'm just gonna keep talking forever, but alas, I do not. Do you guys have any questions? I'm going to cut it there. So we'll go through as much as we can next week. I probably will not be able to finish this whole section unless I can get through, how many slides do I have left? 100 slides in 2 hours? I've done worse, but I don't know if I can do all that. So, so the end of next week will be the end of test material. If I had to guess, it will probably be up through the anti-epileptics. I don't know if I'm going to get far past that. Actually, no, we can probably get through Parkinson's. We'll see. We'll see how it goes. And then we'll go from there. So any questions? If not, let me check the board real quick. One question. What are your thoughts on musicians using valproic acid to try and reopen the critical learning period to develop perfect pitch? I've never heard of that before. That sounds pretty interesting. If that's true, I would do it. That sounds pretty cool. If I got a perfect pitch. I'm in perfect pitch currently. I don't know. It's a good question. You can do some research and come back and tell us your findings via sticky note. That would be good. If nothing else, I will see you guys next week.